right, thank you. All right, thank you for the opportunity to present this work. I'm Brian Epling. I'm one of the ID fellows also in the laboratory. I think so. I think I'm just not speaking into it. Also in the Laboratory of Immunoregulation at the NIH. And so I'm going to be talking about rebound COVID in patients who have received Nirmatrelvir or Ritonavir. So, as I'm sure I probably don't need to explain to anybody unless you haven't listened to the news in the last year, NMVR, as I'm going to say it just so I don't jumble the words, was granted EUA by the FDA in December 2021, which made it the first SARS-CoV-2 protease inhibitor to be made available, and it reduced the risk of hospitalization and death by COVID-19 in an unvaccinated high-risk adult cohort in the EPIC-HR trial from 6.53% to 0.72%. However, in the EPIC-HR trial, and this is the figure from the CEDAR review, there were several patients, both in the placebo as well as the NMVR group, who demonstrated viral rebound at days 10 to 14. And then after NMVR was released, there were multiple reports of patients experiencing symptomatic rebound, which culminated in a CDC health advisory. So this led to several questions that we had. First, the etiology of this phenomenon was of particular interest, and whether or not there was a role of immune evasion because of early viral suppression was of interest as well. The risk of severe disease was also unknown at this time, and the role of potential for viral transmissibility also was unknown. Also, the role of NMVR resistance was also something that we wanted to look into to see if that was also playing a role as well. So this was our cohort. We saw 14 patients. 7 of these patients were acute visits. 5 of them served as acute control participants, and then 2 patients that were seen for acute visits later went on to develop rebound symptoms. So they were seen along with 4 other patients to consist of a 6-patient cohort of rebound after NMVR. There were also 3 patients that were seen later in their disease course. 2 patients were patients who had rebound symptoms without any previous treatment, so they were the 2 patients with rebound without any NMVR, and then 1 served as a late control patient. And so all patients who received NMVR started between 1 to 4 days after initial symptom onset, and the median time to symptom recurrence was 12.5 days after the initial symptom onset, and it was 6.5 days after completing NMVR. Most patients had improved symptoms on rebound. 6 of the 8 reported that their symptoms were more mild than their initial disease course, and then 1 had similar symptom severity and 1 reported worse symptoms. However, no rebound patients required any additional treatment or hospitalization during this period of time. These figures are a few of their laboratory parameters. So their CRP in the rebound group, which is in the middle, the blue here, was lower than the acute participants. Their neutrophils, lymphocytes, and viral loads were all fairly similar across the groups, but the serum nucleocapsid antigen was notably lower in the rebound and late group compared to the acute group. So conclusions just from their clinical evaluation. Their rebound symptoms started on a range of days of illness between 1 to 4, so there wasn't really a clear impact of a delayed start to therapy. Even patients who had started NMVR on day 4 of illness still went on to develop rebound symptoms in our cohort. The symptoms returned on a range of days, 11 to 15 days after initial symptom onset, and in the NMVR rebound group, and then a wide range in the rebound without treatment group between 9 to 20 days. Most had improved symptoms. There was no evidence of progression to severe disease, and there was a decreased CRP in the rebound versus the acute group. So we also conducted virologic evaluation on these patients. The SARS-CoV-2 from nasal swabs was cultured with Viro E6 cells, and infectious replication competent virus was isolated from 1 out of 8 rebound patients. This was from a patient who was on a TNF alpha inhibitor. And after adding polybrine, we were able to isolate it from 5 out of 8 patients. So the polybrine increased it from 1 out of 8 to 5 out of 8. There were no reports of any subsequent transmission from our rebound patients. And the patients who underwent sequencing, there was no resistance mutations that were identified, including one patient who had longitudinal samples measured. So we also conducted immunologic evaluations of the patients. All patients had high levels of anti-spike IgG and anti-RBD IgG, which was consistent with prior immunization, and these were all immunized patients. In the rebound group, the nucleocapsid IgG was higher than the acute group. And while the wild-type spike surrogate viral neutralization titer was similar across the groups, notably the Omicron-specific spike surrogate viral neutralization titer was higher in the rebound and late group compared to the acute group. Additionally, their T-cell responses, so figure A and B here, you can see that both their CD4 and CD8 cells were slightly higher in the rebound group compared to the acute group. And then these are their subsets of CD4 cells, and you can see the responses to spike, nucleocapsid, and membrane were all higher in the rebound group than compared to the acute group. These are the longitudinal patients. And so both of them had a decrease in their CRP, both had a decrease in their serum nucleocapsid antigen, and then both had a rise in their Omicron-specific surrogate viral neutralization titer, and they both had a rise in their, this is their CD4 T-cell responses as well. We also conducted biomarker assays as well. On the left are their markers of innate immunity, and those largely were stable to down, whereas their markers of adaptive immunity were either stable or increased in the rebound cohort. So key findings, clinically, most patients had improved symptoms at rebound. None developed any sign of severe disease or required any additional treatment. Virologically, we did not identify any viral resistance mutations. An infectious replication competent virus was isolated from 1 out of 8 rebound patients initially, and notably that was the patient who is on a TNF-alpha inhibitor. After adding polybrine, this was increased to 5 out of 8. It's unclear which more accurately represents the potential for transmission of the virus. That's certainly something that could be looked into further. And then immunologically, their adaptive immunity appeared intact. So this here suggests that the pathogenesis of rebound may be caused by a more robust immune response rather than uncontrolled viral replication, as has been hypothesized previously. And immunocompromised patients, particularly the patient that we had who was on a TNF-alpha inhibitor, for example, who cannot rely on adaptive immune responses, may require a prolonged course, up to 10 days could be considered, or additional therapies. And as always, this is a numbers game. This was a small group, so a larger group would be required to really get a sense of the incidence and the epidemiological implications of rebound. All right, I think that's all I have.
Thank you so much.